Okay, good afternoon. Thank you for coming in on your time off to learn a little bit about Graves' disease. And thank you, Miss Cindy, for being our videographer for this. I have Abigail and Cassandra and Diego with me, some of my nursing students. And I'm Jeannie Leake, and I'm in the UT Arlington Masters of Nursing Education program. So we are doing a little video on Graves' disease and to talk a little bit about what that disease is all about. So why do we call that Graves' disease?
The founder's last name was Graves, the physician that founded what it was.
Yes, well, actually, yes, we know about hyperthyroidism since early 19th century, but midpoint through there, Dr. Graves discovered that Graves is an autoimmune disease. So what's autoimmune?
The body protects itself.
Okay, and so he's the one who actually found that, and so because he found that, he gets to name the disease, and so it's his disease now, and so that's why we do that. The disease is relatively prevalent in the country, not too bad. As far as hyperthyroidism, it's 85% of hyperthyroidism is Graves' disease, but it will strike about 16 women per 100,000 and about 3 men per 100,000. So the men have an advantage on this, and it likes ex-smokers best. They are higher risk than anything else as ex-smokers for whatever reason, I don't know, but it is common and it's there, and it functions by attacking the thyroid itself, which is stimulating. So the thyroid produces a protein called thyroglobulin, and in that protein it stores T3 and T4, which are the hormones that are released into the bloodstream that support our metabolism and help cell regeneration and our physical activity. All of that is supported with our thyroid. And when we're low thyroid, we're tired and weak, and we don't want to do anything. When we're high thyroid, we're really busy and revving up a little bit. So what happens is when Graves' disease hits, the antibody receptors in the thyroid react to the T3 and T4 when they come out back from the thyroglobulin, used in the bloodstream. They're stored in the thyroid. They react to that, and so it begins. It reacts on the surface of the thyroid gland, and it overstimulates it, and so it begins to shoot out more and more T3, T4. Thyroid stimulating hormone kicks in, and it keeps shoving out more. And when that happens, the thyroid's then stimulated to produce all this, and in order to do that, it has to grow. And so it gets bigger and bigger, and you see people with a growth down the side of their throat. Our thyroid is located right in here, and that's called a goiter. And that's just a result of overstimulation of the thyroid gland. Okay? So that's why that happens. And so we have to figure out a way to reduce how much that produces. So when you have a thyroid gland that's overproducing thyroid, T3, T4, what kind of symptoms are you going to see in a person?
Muscle weakness,
Tachycardia, sweating,
hair loss,
weight loss. They have weight loss. Wouldn't that be a wonderful thing? I think I want to go for that. But they have weight loss because their body is so stimulated. It's just their metabolism is on high gear. When somebody is in that kind of state where they're constantly being stimulated, they get very anxious, and they get very there's a lot of irritability, even in the cardiac status, which is what the tachycardia hits. But a little light touch would just send them off the wall because it's overstimulating them, and they can't tolerate it. Heat tolerance, that's what sweating is. There was one other thing that it was frequent stooling. They can have frequent stooling. They get tremors. That's the hand tremors, and that might be one of the first things that you notice on somebody is they're just a little bit tremoring, and it's usually in the hands, and it's that anxiety that's coming out a little bit in there. The other thing that happens that's very obvious is in the eyes and around the face. Is the eyes, there's swelling that happens behind the eyes, and it causes a protrusion, almost to the extent, in some cases, to the extent that they exceed the stretchability of the eyelids, and so they can't close their eyelids over their eyes anymore. They've protruded so much, and so keeping them moist and protecting that eye tissue is extremely important and can lead to some loss of sight because the eye is irritated and beyond what it can repair. There's also an element in Graves' disease that affects mom and baby. So if you have a mom, because this disease hits an age range that's most prevalent between the age 30 and 50. And so that's certainly an age when women are having children, and especially now when they're having children later and later, it seems like. So if you have a mom with Graves' disease, it can be passed, it does pass through the placental barrier, and it can pass on to the child, and almost certainly will pass on to the child. And so the baby can have some of the same symptoms. They can have tachycardia, there can be irritability, there's more activity in utero, there's a low birth weight, all of those things that people suffer on the outside, they're suffering all by themselves on the inside. And so in order to treat the baby, you treat the mom. And so you can give the mom the same anti-thyroid drugs that you would give, and the baby gets those drugs through the placenta, and their condition is treated. If it's left untreated, it can have some very severe birth defects, and it can certainly, it's life-threatening to them. It can be life-threatening untreated to anybody. And so, so it's not just a little low thyroid or a little bit high. It's a life-threatening condition. So if not treated, left untreated, it would be life-threatening for them. Okay, so the ways that these are treated, there's three ways. First is anti-thyroid drugs. That includes beta blockers. Those help with that. And then there are also two medications, MMI and PTU, and I'm giving you the initials because I know you can read them in your paper, but they're difficult to pronounce. So MMI and PTU are the two medications. MMI is the most popular here in the United States. We don't use much of the PTU. That's used more in Europe and outside of our country. And they are effective. There's actually been one very long-standing study done in Japan about the long-term effects of these medications. Most physicians will recommend 18 months to 5 years on the medications and then wean them off. Because with that much time, it's like it has retrained the thyroid disease the thyroid to be in compliance. Mm-hmm. And so they don't need it any longer. And so they do try weaning out episodes with that. So hopefully they can get that. Now, if they're unsuccessful with medications, there's a thyroid ablation, which is done with a radioactive iodine. The thyroid is very iodine oriented. The iodine helps potentiate that. So you put radioactive iodine in there and it destroys thyroid tissue. Now, it's a hit and miss how much they're going to destroy. You want to leave a little bit less so that they don't have to be on supplements their whole life, but sometimes you have to do it twice if you don't get enough destroyed the first time. And sometimes with the second time around, you become hypothyroid and you end up on levothyroxine or some other type of supplement, okay? The third option is a surgical removal. Just take it out, all right? There is a rare instance of cancer in the thyroid with Graves' disease, but it isn't any more prevalent than just thyroid cancer in usual. But if you're going to remove the thyroid, they recommend that you just double check it for nodular cancer to be certain that there wasn't a dual problem there. So those treatments are pretty effective. You would want to monitor your T3, T4, and TSH certainly after any of those treatments and make sure that those are safe. After a thyroid removal, hypercalcium is an issue. And there could be too much calcium thrown into the system. So when we have too much calcium, we're going to be irritable and shaky and everything else with it. So you want to really monitor that up to a month after surgery. You want to watch for that to make sure that the patient is safe with that. Vitamin D and alkaline phosphatase are two other measures that you're going to want to go along with that. Vitamin D and calcium are closely related, so those are measures that would give you indications that there's a beginning problem with the thyroid again. Okay? All right, so summarizing, we talked a little bit about who Dr. Graves was and why he got that disease name. A little bit about the signs and symptoms, some about the pathophysiology of why this occurs, treatments for it, labs to monitor, and how to watch for those calcium levels up to a month after surgery, and what questions to ask when you're interviewing your patients to make sure that you catch those over-the-counter things that might
Supplements.
cause some problems when unexpectedly. Any questions? Okay, thank you very much. I appreciate it.
Thank you.
Thank you.